Well, I think that's everybody. Without further ado, we are very excited to have one of our star residents teach us for the next 10 minutes or so about this wonderful, fascinating modality called accelerated resolution therapy. It is my honor and privilege to introduce to you, soon to be fully graduated from residency, Dr. Michael Broukhim. I am delighted that he's going to be sharing this with us. He just gave grand rounds on the topic in our department and has been practicing for the past many months working with patients with trauma. And we have other ART practitioners amongst this group. So this will be a lovely reconnection with this modality. Michael?
Yeah, thank you for the introduction. Let me share my screen really quick. Okay. All right, can everyone see the slides? Great.
Yes.
So yeah, I'm really excited to give you all a general introduction into accelerated resolution therapy. We like to call it ART. It's a lot easier. I first learned about ART from Dr. Villa Gomez in my integrative psychiatry track during my third-year residency. And what really struck me was like how enthusiastic she was about ART. And, you know, it seemed like due to the success she had with it, you know, she was just really excited to share it with us. And so I just wasn't used to that level of enthusiasm for like mental health treatments in general. And last year during Labor Day weekend, I took a training in ART and I was really mesmerized by what I learned. And I wanted to start using it in the clinic immediately. And so I did. And I also told a lot of my colleagues about it. And I really enjoyed it so much that I made sure I gave a grand rounds presentation on it. And now I'm really grateful to be able to share it with you guys today. The one disclosure I have is that I actually was paid $650 to be an assistant to a 3-day training, ART training earlier this year. So over these next 10 minutes, I'll go over a general background into ART. I'll go briefly into the research, as well as research that may explain how ART works, and then also talk about my own experience. ART was kind of introduced to the world in 2008 by Lainey Rosenzweig. She is a licensed marriage and family therapist, and she still continues to teach advanced trainings yearly. She also gives monthly support seminars as well once you go through the training. In 2011, University of South Florida started to engage in ART-related research. I think they have around like over 10 studies that they've done there. And in 2015, the Substance Abuse and Mental Health Services Administration classified ART as a evidence-based treatment for trauma-related disorders, depression, and personal resilience. So to get trained in ART, you need to be a licensed mental health provider. Basic training, which is 3 days long. The trainings at this time are only offered by the Center for Rapid Recovery, which are mostly available in the US. And so we usually have, I think there was someone actually in our training a few months ago came all the way from Pakistan to get trained. So here are some general steps to an ART session, and I'll kind of give a real case example that I recently had. I had a patient who was in her 40s who was really traumatized by her firstborn child having to go to the NICU. And, you know, this event had happened over 10 years ago. And so I had the patient recall images of the traumatic event without verbalizing the images or details of the event while engaging in rapid eye movements. And so in between processing her traumatic scene, I would have her notice what physical sensation she was experiencing and then process them through engaging in rapid eye movements and imagery. For example, as she was seeing part of her scene, asked her to pause and notice what physical and emotional sensations she was experiencing. At that time, she noticed that she was having a lot of tension in her neck, a lot of tension in her chest. So I then asked her to use an image to help release that sensation. And so a suggestion I gave was having her use a white calming light passing through her neck and chest. And usually, for a lot of cases, this actually helps relieve the tension that they're experiencing at the time. After having her visually go through her traumatic scene twice and then processing any physical sensations when going through a scene, I then asked her to come up with positive images to replace the traumatic images from the original event while engaging in rapid eye movements. And again, you can give suggestions of positive images as well if the patient is having difficulty with coming up with any. In her case, she used images of her baby being healthy and never going to the NICU. And again, when I mentioned that patients have to engage in rapid eye movements, what I mean by that is as they're playing the image in their head, I will have them follow my hand like this with their eyes only. So what we ended up doing by the end of the session was, I helped her unlink bad feelings from this memory while she was able to retain the facts of what had originally occurred in her traumatic event. A catchphrase that is frequently taught in the training is, keep the knowledge, lose the pain. So in her case, she recalled everything that happened, but again, the pain of the experience had dramatically decreased by the end of the session. So there are a collection of case studies, cohort studies, and smaller RCTs that have evaluated the clinical usefulness of art, and most of them have involved addressing PTSD symptoms, and all mostly showing statistically significant improvements across various measures. Again, due to time, I won't be going into any one specific study, but there's a lot available they can find online. Can everyone hear me? Everyone's okay? So there is some preliminary evidence that it may be useful for OCD, a complicated grief, chronic neuropathic pain. Hopefully there will be more high quality studies evaluating its application to address these issues in the future. Also later this year, it's possible the publication of the cognitive processing therapy versus ART study will come out. It was conducted at the VA in Cincinnati, which is on the right, and hopefully it finished last year, so hopefully it'll come out at some point in 2020. So I'll go into some of the theoretical mechanisms that may explain how art works. Research has shown that consolidated fear memories that are reactivated or retrieved can lead to a brief period of time of reconsolidation and modification. And what I mean by reconsolidation, it's the process that occurs to restabilize and mediate further memory strengthening. And during this reconsolidation phase of fear memories, the memories can be modified with non-fearful information. And so when you introduce a novel non-threatening outcome when reactivating a conditioned response or stimulus, this optimizes the extinction of the fear response. In the case of accelerated resolution therapy, the novel non-threatening outcome is the relieving of negative physical sensations that occur while reviewing the memory visually in one's mind, and also having the patient engage in rapid eye movements. So both components are really important to kind of have that fear response become extinct. So in regards to research to eye movements, in terms of the impact that it has on memory, there's a considerable amount of research looking at this, but there's conflicting evidence. Eye movements appear to help enhance memory retrieval, and while using eye movements to retrieve the memory, you are taxing the central executive aspect of working memory, which in turn helps the emotional and cognitive aspects of the memory dissipate. Research has shown that the more rapid the eye movements are, in terms of like how fast, they can move their eyes back and forth, there is a further decrease in emotional intensity, but not necessarily vividness of the memory. And in one study by Zach and his colleagues, they focused on the visual focus feature of EMDR and studied the difference in clinical effect of eye movement versus patients fixating their eyes on a non-moving hand versus third component, no visual focus on any object. And the results showed that there was a statistically significant drop in PTSD symptoms when taking either visual approach in comparison to no explicit visual focus of attention. But what was really interesting was that there was no statistical difference in the reduction of PTSD symptoms for people that were moving their eyes, having rapid eye movements versus just fixating on just looking at a hand. And in one review, Vandenhouwe and Engelhardt found no evidence that other forms of bilateral stimulation besides eye movement decrease emotional intensity of memories. So like, for example, in EMDR, they like to use tapping and auditory stimulus, and it seems like there's, in this specific particular review, there isn't much evidence for using that. Lastly, in a review article by Miros and Makabach about EMDR, specifically the therapeutic feature eye movements, they discussed numerous studies that showed that, again, no significant effect on attenuating emotional responses to troubling memories. So I think it's really important. I think when Dr. Villa Gomez shared her experience with art, I think, really reminds me of the importance of having people share, kind of their anecdotal experience with art, because I think it can be really powerful, because I know that definitely influenced me to use art. And I think what I'm going to share now, I hope helps inspire you to look more into art. And so what I really like about art is that patients don't have to verbally describe the past traumatic events to me. I've had patients express their appreciation of that. And I also like to not having to hear the details of such events, because it does decrease my own sense of emotional burnout. Actually have found myself close to tears of joy at times because of the relief I see from patients. And it's something that I don't think I'll ever really forget. There's no homework to assign to patients, and I think patients appreciate that as well. It has been perplexing at times for me to see the emotional intensity of the images that in some cases have haunted them for years, just decrease significantly within a 190-minute session. And it sometimes can seem too good to be true. Thankfully, so far, with the patients I've worked with, the changes have been maintained over time without any subsequent sessions. And this is what the research reports as well. Thankfully, our residency program is really open to new treatments. And so I've used art for my long-term therapy patients on occasion. And in one case, it really helped accelerate resolution of symptoms to the point where my patient didn't require any further psychotherapy or medications. I've also been able to accept consults from other psychiatrists and psychiatry residents in the residency clinic for one or few sessions to help process past traumatic events or even situational anxiety, such as fear of driving. And I'll initially meet the consult patient for about 15 to 30 minutes to identify a possible event they would like to process and make sure there are no possible contraindications to starting. This is then followed by a 90-minute session. And in a lot of cases, even though I hadn't spent much time with these consult patients before using art or developing a sense of rapport with them, they've usually been very engaged and they've experienced positive results. Possible contraindications for using art include pending legal action, for the patient involving the traumatic scene that they're being processed, especially if they're going to testify about the traumatic event that they experienced, and also the ability to follow my hand with their eyes. And another one is if a patient suffers from something such as aphantasia, where they cannot voluntarily visualize imagery. So patients that are not able to follow my hands for rapid eye movements or actually keep an image in their head while following my hand, it's going to be hard for them to go through the session successfully. It's not all rainbows and roses with using art. There's a lot of skepticism that you might get from patients, especially in regards to trying to implement positive imagery for rapid eye movements as tools to help desensitize the traumatic images. The other thing that's been really hard, and I think that's why I've been trying to do this outreach of talking about with my colleagues, is there's a lot of skepticism that I've experienced at times that make you question your practice. But over time, as I've gained further experience practicing in the clinic, seeing firsthand patients have really positive results, my self-doubt has really decreased. Sessions are usually 90 minutes long, at least for the first ones, and it can be really tiring at times to go like this for a long period of time without any break, especially for whichever arm you're using to elicit rapid eye movements. But the actual part of processing the images usually does take around 60 minutes, and so the remaining 30 minutes is spent towards some time is spent before structuring the session, but also time is spent at the end for also processing what the session was like. So here are my final thoughts, and I guess the main points I would like to get from the presentation is, there is right now there's limited research in comparison to other gold standard therapies in terms of the volume and in terms of the scale, but this might make people be hesitant in learning more about art or referring to an art provider, but I think the limited evidence that we have available so far has been promising, and there's more to come later this year, such as the head-to-head study. If I had more time, I would discuss how art does have many core components of other trauma-focused therapies, such as cognitive processing therapy, prolonged exposure therapy, as well as EMDR. Art's really quick to pick up. Again, it was just a 3-day training for me, and it's been really easy to implement in my practice during my 4th year of residency, and it's been easy for me to even implement it as a consultation treatment as well. And so far, I've had a lot of patients respond well to it. And so that's why I really view art as a low risk treatment with potential for high benefit in a really short period of time. And lastly, this form of therapy might not be for everyone. As I mentioned, difficulties above, there is a formulaic aspect to art in terms of using a script. However, despite using script, there's still a lot of room for creativity and exploration in terms of ways you can apply this treatment to patients. So thank you guys for listening to my talk, and here are my references, and thanks for your time.